Criteria used in the dental fabrication and the feature dental technology. We are invariably be combined with the artificial intelligence, AI. So with the theme of digital dentistry, we are even more inspired for expand our goal to invite outstanding dental educators from universities around the world to share and discuss the latest breakthroughs and advanced education in the application of dental technology. In the future, the cooperation between dentistry and the dental technician will only become closer. The conference provides a powerful platform for the interdisciplinary educators to share their thoughts and ideas, as well as potential opportunities for the international cooperations. This conference is the first meeting between Taipei Medical University and the University of Erlangen in the field of dentistry and the dental technology. I hope the cooperation and the exchange between the two universities can continue to operate in the future. Regarding the behavior of the organization committee, I would like to express my serious welcome to all participants and friends for their participation and contributions. I also thank our committee members for their tremendous role in co-organization meeting and the programs. Finally, I wish we can meet each other in the next year. Thank you very much. Please enjoy this meeting. Thank you. Bye-bye.
Thank you, Professor Shen, for the excellent talk. Once again, thanks to our guest speakers to giving us inspirational speeches. Also, thank you all for attending our conference. This is the end of our opening ceremony. Before we continue on to the following section, let's invite everyone gathered to take a group photo. So please turn on all of your cameras. And, oh, please wait more. Wait. Okay, I count 1, 2, 3. Okay, thank you very much. So I would like to invite the Professor Hendro. Handy. But
thank you, Prof. Ben. Nice to meet you. Okay. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Dear Professor, Doctor, and all participants of the seminar, thank you for being here today at the meeting of ICDD 2022. My name is Hendrik Setiabudi. It's an honor for me to speak on behalf of the co-host Faculty of Dental Medicine, Universitas Airlangga. For your pieces of information, we have 2 sections, and 2 speakers will give a presentation in each section. Before the presentation start in first section, please let me to invite Dr. Ramadan Hardani Putra, DDS MDSG, as moderator for Prof. Wecunlin. Okay, please, Dr. Ramadan, time is yours.
Thank you, Dr. Hendrik, for your kind introduction. Good morning, everyone, and welcome to the first session of International Conference for Digital Dentistry 2021. And yeah, I'm so glad that today we have so many participants. I see around more than 200 participants today. So yeah, my name is Ramadan. I'm a lecturer at Faculty of Dental Medicine, Universitas Airlangga. And today I will be your moderator for this first session. First of all, I would like to welcome our honorable speaker, Dr. Wei Chunlin from School of Dental Technology, TMU. Good morning, Dr. Lin.
Yeah, good morning.
How are you today?
Okay, yeah, I feel so good. Okay.
Okay.
Thank you.
Thank you for your time, and we are very pleased to have you here. So before we start the lecture, let me read his curriculum vitae first. So Dr. Wei Chunlin is a dental technician and assistant professor at the School of Dental Technology, TMU. And for educational background, he obtained an associate degree in dental technician from Minhui College, Taiwan in 2013. And in 2019, he earned his doctorate degree from Chung-San Medical University, Taiwan. And he is engaged in the practice for digital teaching and prosthodontics at the School of Dental Technology, TMU. Dr. Lin's research interests include clinical dental implant research, ceramic restoration, and digital dentistry. He also has published many clinical articles in peer-reviewed journal. And today, Dr. Lin will give us an interesting presentation about the novel and efficient digital dentistry technology. And this topic will show us the technique in digital workflow that can save model making time, minimize the error, and complete the dental restoration with more efficient. And this presentation will be given in around 30 to 35 minutes and then followed by discussion section. To Dr. Lin, are you ready?
Yes, I'm ready, and I show my PowerPoint. Yeah,
okay.
Wait. Okay.
Yes, we can see your presentation, and you may start your presentation.
And the sound is okay.
Yeah, we can hear you clearly.
Okay. Please wait because the PowerPoint will open. Sorry. Okay. Good morning, everyone. My name is Wei Chun Lin. I'm come from the
Sir,
Taipei Medical University. Yes.
can you have a slideshow for your presentation because it's
Okay. Sorry.
a problem.
Okay, I have some question. Sorry.
So take your time.
这个要我应该有播放。Okay, show my PowerPoint. Yes. Okay. It is clear.
It's clear now.
Okay, and I beginning my yeah.
But
It's okay.
We can see your PowerPoint, but it's darker. It's look.
Okay. Sorry. 可以帮我吗？我现在要。OK，老师可以帮我一下吗？
他现在好像没办法秀，是不是？你先把影片放出来嘛。
这样呢？这样有吗？
我要去看一下。
Okay.
It's clear now.
I'm very sorry because my computer have some wrong. Okay. I begin today my presentation about the novel and innovation digital dentistry technology. My name is Wei Junling, CDT and PhD. I come from the Taipei Medical University School of Dental Technology. Okay, the dental restoration system is will affect the contribution of the patient mouth restoration. Digital restoration use the maybe by dentistry use impression material to copy the set of the teeth in the patient mouth. In a introduction, finally, it will be delivered to the dental technician for the model preparation, testing, and the restoration produced. This step takes a lot of the time and the washes stone. This result is in a 3 to 7 day working time for the digital restoration. Therefore, it is a major challenge to shorten the restoration time. So before the clinical trial, we use the impression and the WhatsApp doing the dental restoration about the crown, complete denture or a bridge something. Right now, after the clinical trial, we use the digital dentistry about the oral scanner, digital scanner, and the digital design. So the change is very big in the working model. Before we use the model to doing the something working about the crown or what's up. And right now we just use the digital model to design. So this change is very big. Okay, we can see the clinical trial process before. Impression and the model making, what's up, and environment and casting, and the ceramic stacking, and the stand and glass. File about 1 crown needs to 3 to 7 days. So the time is very long. But right now we can see the clinical trial process after. The digital trying, we can use take oral photos and the teeth preparation. Okay, teeth preparation times have a big challenge. The range is so big because maybe sometimes you just doing the single crown or short bridge, long bridge. So the range is very big, but about 30 minutes to 90 minutes. And next step is the oral scanner, about 5 minutes, so it's very quickly. And next step, we just use the digital designs about cat. I think maybe 20 minutes enough to design the one restoration. And then the other step is the meanings about the ceramic, metal, or resins will be meaning to get a restoration, the crown or some things. So it's very quickly, about 10 minutes. And this step, we can modify the crown morphology. So, and the stand and glass about 25 minutes because the stand needs to time is not change. Okay. So the deliver and trying, maybe 10 minutes you can do it. So total all the clinical trial process times about 3 hours. Those 3 hours you can finish the 1 crowns to restoration. So today I want to show maybe the process how to do and to introduce every one step, show my clinical experience for everyone. Okay, so the one step is the take oral photo because we need to color in method. So use the photo, use the camera to take the patient teeth, and the other machine to know the veils. Okay. And the other is the teeth preparation. We need to preparation the teeth and the scanner. So the preparation needs to see. You need to see the. Okay, so this one, the video we can see the titan print need to no undercut in the abutment. So you need to check every one abutment, no undercut in here. So I think in a digital oral scanner and digital model, you can see that everyone undercut have or no. Okay, and before, after we print the crown, and we can see the other video. Okay, sorry. Because this one is the one piece, the long bridge. So you need to see everyone apartment have the undercut or no. So you can see, use the 3D print, the teeth is very fit. the marginal gap is very small. Okay, this one is the teeth preparation. And if you finish the preparation, the next step is the oral scanner. Before the clinical trial, maybe use the impression, but right now we use the oral scanner to take the models. And this one have the video. It's very short to take the oral scanner. Okay, so you can see the video is very short, about the 2 minutes, about the 30 seconds. So it's very quickly to oral scanner. And this one, next step is digital design, the CAD/CAM. About right now have many more companies have many more system for the dental design about the Zen and 3Sharp and this Dentistry, Sirona or SOCAD, and have the other, but the 4 companies in Taiwan is always use. Yeah. So today I want to introduce the in-lab process for everyone. The in-lab CAD and the process is the country order and the message and the add model and the next step design and the explore and finish. You can take the STL to mini or to watch your restoration is good or needs to modify. So next video, I will show my, I use the Select to design the 1 crown, the single crown restoration. So we need to change which one is the, we want doing the teeth and the style and the companies and the materials. And next step, we need to talk the surface, how to the teeth want to do, because this is the oral scanner. The computer knows which one is right, the abutment. So you need to put in the right, and we can see in here is the code of the Wilson, and then the other is the code of the Spears. And this one, you need to talk everyone the teeth about use the point. The 1 point is put in the incisor, and the second point put in the canine and the premolar. And this one, you need to put in the premolar and molar. Finally, is put in the second molar. And we need to cut the other models because this teeth can cut. Because we need to write the margin. So right now you can very clear to watch where is the margin. And we need to modify the marginal line. That is very important. Marginal line is not easy or easy. It's very important to find. And this one, you need to watch the pathway. Because if you have the upper part Okay, next step is very important because you can set up the cement space or occlusion space or marginal gap. How many you can to set up? Because if you use the mini machine, and after mini will be cut more in your crown. So you need to set up the right the space for your crown. Okay, in right now, surface can help you to design the teeth morphology. About this one, you can to see very easy to put in the one crown and to get a right, you can change the size or a function or something, and we can see. And the other surface can tell you by the color is the over. So you next step you can modify to high. You can to cut. Okay, right now you can to see the occlusion or the occlusion function. You can to find is right or not to modify your teeth. Sometimes you need to change the contact angle. So in the surface, you can to change the contact angle if you want to change, but usually don't change the number because the surface is right for your restoration. So you can to change, yeah. So maybe we can quickly do video. And you can see watch the video, very more about the inclusion of couple sign, single sign. To watch is okay or not okay for your morphology. And the contact you need to modify because low and over will be don't clean your mouth. It's very important. Okay, finally, we use the material and choose which one, and you can to use the mini machine to mini the crown. Okay, this step is the broke because the broke is very quickly to mini about one broke for one single crown, about 10 minutes and you can finish. So in the clinical trial, it's very quick. Okay. If you finish the design, next step is the mini. This one we use the KCAM, the Dentistry Silona, the MC-XL, the machine, and this have the video to introduce how to the mini the single crown. Okay, it's finished. So we can see this material is the ceramic, the glass ceramic. And this one, the material is very beautiful in the clinical trial about the veneer or in the onlay you can use. So next step, we introduce the block about the glass ceramic. Right now have many more type and many more companies have the block for the dentistry, the digital dentistry KCAM about the chair size. And we can see it about the cell tradu and the IPS image scan is very always use the material. Yes, next one is Lambita Mark II. And the other have the new material. This one is the amber meal. Okay. And right now, because human teeth is very more the color and the translucent, and so the material needs to very more color and translucent for the patient use. So you can see about the IPS image scan have a many more color, and you can choose. And the high introduce truth and MT, HT, LT is very more different, and the MO. Okay. So right now, next step is the staining and the glazing. Okay. The featured original is the Laconia crown. We can see it's the very white, but right now, material is very better for the stain, and you can see about the Vita, Biomilk, Mio or Emax have a very more stain material, and to change the white color, and to give you the neutral teeth color. So it's very new. And if you want to try the color, you can use the watch to try the teeth color. You can see we use the rainfall GEO watch. It's very more the color. Have the dentin edema or transduce, the very more, and the special color is the orange, brown, and the blue or white. So you can see in the in the Mona, we can see this crown is use the wax material to do it. So the color is very beautiful in the cast. So finally is the finish your crown restoration. About the you can see it the very more veneer in your mouth, and the other cast is about veneer in this. And if you have the inlaid or unlaid or overlay cavity, and you can see use this one, the glass ceramic do it. So and this one. So in the clinical, the dentistry, digital dentistry is the change. Okay, we can see in the clinical treatment process. After, sorry, I wrong. You need 2 days to finish your working. The 1 day, the time evaluation and the denture introduced. The second time, the teeth preparation and finish your dentures. So you just about 2 days, you can finish your work, your trying. In the school, we use the KCAM system to teach students about a high school student to experience. So it's very easy because the student is not any experience for the dentistry or dental technology. So this student can use. So the KCAM system is very easy for everyone. And the other have a very more digital restoration about a CD, a company denture, and the RPD, and aligner, and the surgical guide. This one can use the digital surface to doing. So I think it's very more restoration can use the surface to do. To summarize, this digital transformation of the dentistry reduce working time. In addition, all information on the produce of the restoration will be recorded, and looking forward to more application of the digital surface in the future. The other in my lab, the other projects, we doing the dental restoration about DSD, the glass ceramic, or image, the medical image about MRI, CT, or target material. and the bone restoration about the hygienic appetite application. So in my research, the two sections have, the one section is the biomedical science, and the other is the dental prosthodontic science. So this is my my lab, my student about the master and the dental school of dental technology student. Yes, and thank you for your listening. I finished my report. Thank you.
Thank you very much, Dr. Lin, for your insightful presentation. And now let's move to the discussion section. So we have around 5 minutes for Q&A section. So please, if for participant, if you have any question, you can type your questions in the chat box, or you can also turn on your microphone to ask directly to Dr. Lin. So is there any question? So while we are waiting for the question from the participant, may I ask some question, Dr. Lin? So yeah, I'm actually a radiologist. So I'm a dental radiologist. So I'm very interested in the imaging technique, using the oral scanner.
Yes.
Yeah, what I understand is there are two kinds of oral scanner technique. There is intraoral and extraoral or desktop oral scanner. So did you use both of that technique? So because I also read some paper that there are some consideration of error potential between different technique like intraoral and extraoral scanner regarding the accuracy of the result between intraoral, because in intraoral we directly scan the intraoral condition, and in extraoral condition we need to use the case model and then scan that model. So do you have any consideration between those two techniques?
I think the oral scanner is very is set because the difference about about 20 microminutes. Yes. So if different companies overall about the 20 microminutes, so I think is can use. But if you in my research, I try to compare if you use the oral scanner or table scanner, summarize, and the impression is if you want to use the impression, it's okay because the difficult is very small. But if you want quickly to finish your restoration, I think maybe oral scanner is quickly to do because you don't to make the models. Yes. So I think right now the oral scanner is not different the companies or something. Yeah.
So it's even there is some deviation, it's still clinically acceptable.
Yes. Yes.
So okay, thank you for your answer. And maybe okay, can I ask one more thing? So you showed in your presentation previously that you have a long bridge, full bridge for in the model. Is there any difficulties? Because I also know that the accuracy might be decreasing when you scan the long edentulous ridge. Is that correct?
Yeah. The long bridge about the 4 arch, is very difficult because in the patient mouth, preparation is the degree is different, so difficult to preparation. But I think maybe you can use the oral scanner and to see the monitor to see where have the more undercut. So the single crown is okay, but the full arch, I think maybe you use the computer surface oral scanner, the digital can help you to preparation. Yeah, you mean it's right. It's difficult for the full arch.
Okay.
Yeah.
Okay, thank you very much for your answer, Dr. Lin. So yeah, I think I'm sorry, but the time for this session maybe is over. So from Dr. Lin's insightful presentation, I hope we can improve our understanding about the application of novel and efficient digital dentistry in our clinical practice. And yeah, let me summarize Dr. Lin's presentation. So by creating a digital model using digital scanner and then followed by digital design using CAD/CAM technology, we can save time and complete the dental restoration with more efficient. So once again, we would like to thank Dr. Lin for sharing your knowledge to all of us. And yeah, I hope we can meet again personally and have a collaboration, because I saw your project that you also have a research in imaging area. So maybe we can have a collaboration.
Yeah. Okay. I'm very happy to discussion about the email or something we can to take about the researcher. Yeah.
Okay. Let's.
Thank you.
Okay, we are very truly impressed by your speech. So please receive the virtual certificate of the appreciation as shown in the screen. Let me screen. I'm not sure. Okay. As shown this screen. Oh, sorry. So as shown in this screen, we will send the hard copy to you after conference. Also, we would like to thank our moderator, Dr. Ramadan. So also, we will send you the hard copy to you after conference.
Thank you very much.
Okay. So once again, I would like to introduce myself. I'm Pei-Wen Peng, a professor from Taipei Medical University. Now I'm going to introduce our next speaker. We invite the specialist who has worked on radiographic imaging, artificial intelligence in dental radiography, radioprotective agent, radiologic in forensic odontology, and radiation biology since 2008. She is now the oral radiologist in Alalanga University Academic Dental Hospital. She will share the current application of computed tomography in Indonesia in the following 40 minutes. Now, please join me in welcoming the Association Professor Eha Ranwi Astuti.
Thank you, Professor Feng, for the time given to me. I will share screen. It is clearly seen. Okay, good morning, everybody. First of all, I would like to thank my exchange special to organizer 222 International Conference for Digital Dentistry, Taipei Medical University and Universitas Erlangga for invite me in this event to present about dentomaxillofacial radiology in Indonesia and specifically about application of CBCT in Indonesia. I'm Eharen Astuti. I'm a faculty member in Department of Dentomaxillofacial Radiology, Faculty of Dental Medicine, Universitas Erlangga, Surabaya. My today's presentation include introduction, dental faculty in Indonesia, dentomaxillofacial radiology in Indonesia, distribution of CBCT units, distribution of CBCT cases, and the last one is the summary. The data I will present come from Indonesian Dental Faculty Association, Indonesian Dentomaxillofacial Radiology Association, Indonesian College of Dentomaxillofacial Radiology Association. To start my presentation, let me give you an overview about Indonesia. Indonesia is located in Southeast Asia, sharing land border with Malaysia, Brunei Darussalam, Papua New Guinea, and Timor-Leste. Indonesia is neighboring country with Singapore, Malaysia, Cambodia, Vietnam, Philippines, and Australia. I must first explain about Indonesia because Indonesia is very different from Taiwan. Indonesia is an archipelago, more than 17,000 islands, and with some large islands like Sumatra, Java, Kalimantan, Sulawesi, Maluku, Papua, and Nusa Tenggara. The population in Indonesia about 250 million people, with fourth most populous country after China, India, and United States. Indonesia consists of 34 provinces, with the capital city is Jakarta, and Jakarta is located in Java Islands. Now, we are going to talk about dental school or dental faculty in Indonesia. There are 32 dental school in Indonesia, 17 public dental school, and 15 private dental school. We can see in this slide that dental school in Java Islands are 19, and in Sumatra 6, in Kalimantan only 2, in Sulawesi 3 dental school, and 2 dental school in Bali. Dental school in Indonesia are not well distributed because the dental school concentrate in Java Island. There is still no dental school in Maluku, Papua, and Nusa Tenggara. In Jakarta itself, we can see in this slide there are 4 dental schools. So, before we continue to the application of CBCT, Let me first explain the existence of dentomaxillofacial radiology in Indonesia because it is closely related to our topic today. This is the timeline of dentomaxillofacial radiology in Indonesia. In 2002, Indonesian Dentomaxillofacial Radiology Association, or ICDD, acknowledged by Indonesian Dentist Association. And then in 2004, Indonesian Board and College of Dentomaxillofacial Radiology established. In 2008, the first dentomaxillofacial radiology specialist study program opened in Faculty of Dentistry, Universitas Padjadjaran Bandung, and at the same time, the first CBCT unit was utilized. In 2014, Indonesia became the host for 14 Asian Academy of Oral and Maxillofacial Radiology Annual Congress in Bali. In 2019, we established a scientific publication or journal international by ICDD with the name Journal Radiologi Dentomaxillofacial Indonesia. In 2020, the second dentomaxillofacial radiology specialist study program opened in Faculty of Dentistry, Universitas Indonesia, and in 2021, Universitas Hasanuddin in Makassar also opened the dentomaxillofacial radiology specialist study program. And Faculty of Dental Medicine Universitas Erlangga will open soon dentomaxillofacial radiology specialist study program this year. Here I would like to describe an overview about dentomaxillofacial radiology specialists in Indonesia in base of island. Up to now, we currently have a total 69 dentomaxillofacial radiology specialists in Indonesia. There are 41 living in Java Islands, 9 in Sumatra, only 2 in Kalimantan, 3 in Sulawesi, 4 in Bali. It indicates that dentomaxillofacial radiology specialists are not well distributed. There are no dentomaxillofacial radiology specialists in Maluku, Papua, and Nusa Tenggara. This is a chart of dentomaxillofacial radiology specialists who works in university. There are 49 dentomaxillofacial radiology specialists who works in university. Actually, the problem of dentomaxillofacial radiology specialists is unequal. The most of them are living in Java Islands. There are many dental schools with only limited. We can see here only one and dental school, only one dentomaxillofacial specialist in one dental school. Even this is no the MFA specialist. There are many dental schools without dentomaxillofacial radiology specialists. Now I would like to explain about the distribution of CBCT unit. There are 32 public and private dental school in Indonesia. In this slide, we can notice blue and red dot indicating dental school. There are 17 in blue dot CBCT units in dental school, and the red ones are 15 dental school without CBCT unit. We can see that the CBC unit was concentrated in Java Island. This slide also describes the distribution of CBT unit in Indonesia, but not only in dental school, but also in private clinic and imaging center. There are a total 72 CBCT unit in all around Indonesia. Actually, we have more than 72 CBCT unit in Indonesia, but some of them are not well registered and assessed. As you can see here, the distribution still concentrated in Java Islands. And in Jakarta itself, there are 17 CBCT unit. Next, I would like to explain the availability of CBCT in Indonesian universities. In 2008, the first CBCT came to Indonesian universities belong to Universitas Pajajaran, Faculty of Dentistry, Universitas Pajajaran, Bandung. And then in 2016, Faculty of Dental Medicine Universitas Erlangga bought a new CBCT unit. And in 2015, Faculty of Dentistry Universitas Trisakti also bought a CBCT unit. From 2016 up to now, there are 14 dental school with CBCT unit in Indonesia. There is a significant increase in the number of CBCT. And now we have 17 CBCT unit in Indonesia Dental Hospital. Let us continue to the distribution of CBCT cases. The CBCT cases came from 5 universities, Faculty of Dentistry Universitas Pajajaran Bandung, Faculty of Dentistry Universitas Gadjah Mada, Faculty of Dental Medicine Universitas Erlangga, Faculty of Dentistry Universitas Trisakti, and the last one is Faculty of Dentistry Universitas Sultan Agung Semarang.
Ternyata kalau basah ada alatnya.
This picture describes various cases from the year of 2008 to early 2021. Figure 1 is explain about percentage of CBCT cases in Indonesia. We can see in this slide that impaction and implant are the highest. In figure 2, this is a CBCT cases distribution based on the year. The highest cases occur in 2019. Due to pandemic, there was significant decrease the number of CBCT cases. The slide indicates indicate the type of CBCT cases based on the year. In 2012 to 2014, we can see the impaction in the blue bar is the higher cases. And then in 2015, beginning 2015, 2016, and 2017, there was significant change of the cases. We can see in implant in blue, in orange bar overtook impaction. In 2019 to 2021, the case of impaction in blue bar back to the highest. Now we come to the distribution of CBCT referrers. It shows that dentomaxillofacial surgeon dominate. It indicates that the utilization of CBCT unit for treatment and evaluation of the surgery. These graphs also show that the least application CBCT is in pediatric patient. We can see there is 1.9%. Since we know that the growth and development in children must be taken to consideration to not perform CBCT. This graph shows the CBCT cases distribution based on field of view. They may related that previously has been shown that the highest is impaction, thus large FOV is usually chosen. For the large FOV, tooth impaction is the most using large FOV and followed by dental implant. In the medium size of FOV, it's shown that implant treatment is still dominate. For the small size of FOV, it's shown that endodontic cases is the highest number. The next one is about distribution of CBCT in dental school hospital. First slide is data from Faculty of Dentistry, Universitas Padjadjaran, Bandung. The three highest cases are impaction, endodontic, and periodontics, and then followed by 5 highest case include implant, cyst, benign tumor, TMJ disorder, and cleft palate. The second data is from Dental Hospital Universitas Erlangga. The highest cases is implant and then followed by impaction. And the third data is from Faculty of Dentistry Universitas Trisakti. The highest cases is implant and then followed by impaction. For the fourth data is from Dental Hospital Universitas Gadjah Mada. The high cases is impaction and followed by implant. And the last one is the data from Faculty of Dentistry Universitas Islam Sultan Agung Semarang. The highest cases is implant and then followed by benign tumor. Here are some points for the conclusion of my presentation. For the utilization, CBCT was firstly introduced in Indonesia in 2008. The MFR specialists are very limited in number and not well distributed in Indonesia. From 2019 to 2021, there is a significant increase in its utilization. Limited number of CBCT belong to dental school. For the case distribution, only 5 universities with dental hospital in Java reported their CBCT cases. Most frequent cases are infection and implant. Most reason for using CBCT is for oral surgery procedures. I have some closing remarks. So as a MFR institution in Indonesia, we need to firstly continue increasing the number of the MFR specialists and promoting even distribution throughout Indonesia. Secondly, to continue improving our competence as the MFR experts to give the best healthcare service. Finally, I hope this presentation can help to give a better overview about the progress of CBCT utilization in Indonesia with its unique geographic and demographic condition. And to close this presentation, I would like to thank to all those who have helped so that this presentation can run well. Thank you very much for your attention. I will return the session to Professor Pak.
Please, Prof. Pang.
Okay, thank you. Okay, thank you very much, Professor Ehab, for your excellent presentation. Now the floor is open for discussion. We welcome your questions and comments for Professor Ehab. As I see in the chat box, there are a lot of questions. Should the attending to ask by yourself, or I just speak out?
I will read myself. Okay.
Okay.
This is a question from Ahmad from Malaysia. Yes. I'm interested and would like to know more regarding the decto-maxillofacial radiology in Indonesia. I think it is the same as what goes in my country, that this specialty is still in a small number. Regarding to the development of technology and digitalization in dentistry nowadays, what can this specialty do, or what is the role of the MFR specialist in the digitalization era in dentistry? Well, this is the first question. The second question, do you have any research topics related to the development of digital dentistry, specifically in the field of the MFR? What kind of research areas have you conducted? Did you also
do cooperation with other fields outside dentistry? And the next one, I think it will be a good challenge to do the research alone, such as for the digital technology or developing artificial intelligence?
Okay. Thank you very much for the
questions.
question from Ahmad from Malaysia.
Yes.
Yes, okay. As we know that digital flow needs several imaging modalities such as CBCT and intraoral scanner. These modalities can be used for various treatment, for implant planning to surgical guiding. So our role as dentomaxillofacial radiology specialist, we have to provide optimal digital data as a main component in digital workflow. Yeah, because the accumulation of error at each step in digital workflow can negatively influence the final outcome. Nah, so together, dentomaxillofacial radiology specialist with dental surgeon, dental technician, we can share our expertise in order to provide better treatment planning for patient. Another role of dentomaxillofacial specialists nowadays to develop an artificial system can help a diagnosis. As we can see that artificial intelligence and digital dental radiography has been increasing over past decade. Artificial intelligence-based strategies need to be integrated to make the workflow more simple, more accurate, and efficient. Therefore, dentomaxillofacial radiology specialist is closely related with digitalization in dentistry. And for the second question, I have many research topic related to the development of digital dentistry, specifically in the field of dentomaxillofacial radiology. Right now, we in Department of Dentomaxillofacial Radiology, Faculty of Dental Medicine, Universitas Erlangga, we are doing collaborative research with informatics engineering from Institut Teknologi Surabaya to develop automated dental implant planning using CBCT radiographs. We develop a deep learning program that can automatically segment the mandibular canal and measure the available bone to choose ideal implant. As a DMFA specialist, we provide the CBC data, and then we prepare annotation of the data set, such as a segmentation of alveolar bone, mandibular canal, and alveolar bone measurement. We also prepare the test data to be compared with artificial intelligence model developed by informatics engineering from Institut Teknologi Surabaya, our collaborator. And in our collaborator, they are doing optimization of artificial intelligence model. Okay.
Okay.
And the
yes, I'm sorry. Please go ahead. I'm sorry.
And the third question.
Yes, do you have any cooperation with other outside dentistry?
Okay. I have been research activity with informatics engineering, biotechnology, and odontology forensic. With informatic engineering, we have conducted collaborative research on a computer-aided system to detect cortical bone change. There are osteoporosis or osteopenia or normal using panoramic radiographs. We have published several journals, and with biotechnology, we are doing research related to herbal material like mangosteen, Morinda citrivalia, or Solanum lipocarcium for radiation protection. And with odontology forensic, we are doing research about radiomorphometric research of mandible to predict gender for odontology forensic purposes. Okay.
Professor Adam, I'm sure this name, but I think if you have more questions, maybe you can ask Professor via email. So would you please go on the next questions? Because from the Yang Tran Jie, she or he want to ask you about why the dental school CBCT unit DMFR specialists are concentrated more in Java
Islands. Okay, thank you, Dr. Trah Nguyen Yen, for your question. So there are several factors why dental school or Faculty of Dental Medicine, Dental Maxilloradiology Specialist, and CBCT unit concentrate in Java Island. First, the oldest dental school or Faculty of Dentistry are mostly in Java Islands. The first is the oldest dental school are mostly in Java Island, such as a Faculty of Dental Medicine Universitas Erlangga, which was built in 2028. Also, Faculty of Dental Medicine Universitas Gadjah Mada, which built in 1948. Faculty of Dentistry Universitas Padjadjaran was built in 1959 and followed by Universitas Indonesia was built in 1960. So the oldest Faculty of Dentistry is mostly in Java Islands. Another factor, Java is the most populated islands in Indonesia. About 60% population of Indonesia live in Java. This causes the need for the MFA specialists and CBCT unit for education and services to be concentrated on Java Islands.
Okay, but it's almost need to close the section. Would you please other question while email to response for other for
Okay.
the audience?
Okay.
Okay, thank you.
Thank you.
We will truly impress. Let me show. Yes, we were truly impressive your speech and the response, the audience response. So please receive the virtual certification of appreciation as shown in the screen. We will send the hard copy to you after conference.
Okay, thank you, Professor Fang.
Okay, I will close this section, please. Let's take 10 minutes exchange. The next section, keynote speech, will begin at 10:30 for Indonesia Standard Time and 11:30 for Taiwan Standard, about 11:40 for Taiwan Standard Time. Bye-bye.
Okay, thank you, Prof.
Second speaker is
Taipei Medical University was established in 1960. It's located in Taipei's prosperous Xinyi district, near the world-renowned Taipei 101 skyscraper. TMU started 60 years ago with the first 3 schools, medicine, dentistry, and pharmacy, and only 250 students in 3 rudimentary buildings with aluminum sheet rooftops and the bare minimum of medical equipment. Upholding the school motto of sincerity and honesty by students and faculty members, TMU has metamorphosed into a comprehensive medical education network, boasting 2 separate campuses and 6 affiliate hospitals. Revenue from school and hospital management and the number of SCI qualified papers has seen substantial growth in the last 2 decades. Led by a board of directors and successive deans, TMU has made enormous progress. TMU comprises 11 schools and a center for general education, which is home to more than 6,000 students and 6,000 alumni globally. TMU's world-class performance has been consistently recognized by the QS World University Rankings and the Times Higher Education Asia University Rankings. TMU was awarded the title for Best Medical and Private University successively in 2020 in Global View magazine's Taiwan Best University Rankings. TMU's research subjects in clinical medicine, pharmacology, and toxicology are ranked in the top 1% of essential science indicators. TMU expands the horizons of biomedical leaders with its humanities solicitude, creativity, and global vision. Based on the concept that education is not for the present but for the future, TMU's College of Interdisciplinary Studies, echoing the global trend of distance learning schemes, offers visionary micro-learning programs and gives students the opportunity to explore cutting-edge fields, including artificial intelligence, big data, and entrepreneurship, to cultivate comprehensive, future-ready skill sets. TMU has introduced a state-of-the-art AR/VR digital learning program and established a virtual intensive care unit and operating theater. Through VR technologies, transformative and engaging learning opportunities are provided. TMU offers hundreds of up-to-date learning courses as part of its massive open online course, MOOCs database, attracting more than 100,000 students from Taiwan and abroad and revamping the traditional classroom learning approach. To enrich students' understanding of humanities, arts, and culture, TMU cooperates with Academia Sinica and the National Palace Museum to give students the opportunity to learn from rich cultural treasures. In addition to classroom learning, TMU encourages students to participate in a diverse array of on-campus clubs and sporting activities. Their outstanding contributions have received local and international recognition, a testament to their selfless service. In terms of research, TMU has established multiple excellent research teams in clinical and translational medicine, with particular emphasis on the areas of cancer translational medicine, neuromedicine and thoracic medicine, artificial intelligence treatments, cell therapy and regenerative medicine, and in the R&D of biomedical equipment and materials, cardiology, urology and nephrology, developing precision health with full support. The quality and quantity of SCI papers has increased annually. Annual growth in research protocols and budget, increase in annual patent approval and technology transfer. TMU has also established the Office of Data Science for the development of AI and data science, and has established a Precision Health Research Center for charting the course for the big health industry. It has created a medical accelerator and startup venture funds to promote R&D innovations. TMU has also established a few affiliated startups with capital of more than $38 million. 3D Biotech Incorporated will be listed on the emerging stock market soon. At Shuanghepi Base, new buildings for biomedical tech, teaching and research are being built, part of TMU's innovative biomedical system and an important hub for international biomedical technology. TMU is actively allied with the international community and collaborates with NIH USA, Johns Hopkins University, Case Western Reserve University, University of Southern California, Imperial College London, Université de Lille, and Hokkaido University. The number of international co-authored papers increases year on year, as does the number of foreign teachers and students, a testament to TMU's effort to achieve internationalization. Ever since 2009, TMU's medical mission teams have been stationed in the Kingdom of Eswatini and the Republic of the Marshall Islands, providing crucial services in maternal and child health, tuberculosis and parasite prevention, among others. In collaboration with the government's policy, TMU has enhanced its cooperation with new southbound countries, such as TB disease prevention in Vietnam, to support Taiwan's foreign diplomacy. Pursuing excellency is an endless path. The Dreamway Building and College of Humanities and Social Sciences buildings were completed in recent years. The construction of the Proton Therapy Center is currently underway, as well as the Taipei Cancer Center and Shuanghe B Base. Aside from the hardware and facilities, nurturing talent plays an important role in TMU's growth. The Leadership and Executive Accelerating Development Program is in its 5th iteration, cultivating more than 100 junior and senior executives. In recent years, TMU Hospital, Wanfang Hospital, and Shuanghe Hospital have promoted a patient-first core value by providing the highest quality medical services to our patients, applying medical big data and Internet of Things, and fostering artificial intelligence such as blockchain, digitalized ward management, and full development of smart hospitals. The specialties of TMU Hospital are cleft palate craniofacial surgery, reproductive medicine, and the Da Vinci surgical system. Wanfang Hospital specializes in cardiology, hyperthermic intraperitoneal chemotherapy, TB prevention, and holistic care in aging. At Shuanghe Hospital, neurology, renal and urology, orthopedics, and organ transplants have all achieved distinguished results. The Taipei Cancer Center pioneers innovative services, including personalized precision medicine, healthcare navigator, and early phase international clinical trials. Taipei Neuroscience Institute leads dynamic robot-assisted innovation on brain surgery and non-invasive therapies for movement disorders, surgery for cerebrovascular diseases,
Okay, Prof. Peng, we can start now.
Yes, sure.
Okay, dear everyone, thank you for Dr. Wei Chunin and Dr. Eha Renbi Astuti for making first section very impressive and informative to us. And then for second section, I will invite Dr. Andra Rizkiawan, DDS PhD, specialist oral maxillofacial surgery consultant, as moderator for Prof. Xia Yufu. Dr. Andra Rizkiawan, you are here?
Yes, I'm here. Thank
you. Thank you, Dr. Andra. Please, time is yours.
Okay.
Wait, Prof. Chewu, I invite Dr. Andra first.
Okay,
to introduce.
My bad. Okay.
Okay, sorry. Thank you. Dr. Andra. Wait. Okay, wait 1 minute. I'm sorry because in Airlangga University we have 2 agenda for today. I will call Dr. Andra first.
Hello, good morning, Dr. Hendrik. I'm sorry.
Okay, Dr. Anda, I'm sorry to bother you because you are very, very busy as Vice Dean in Faculty of Dental Medicine Erlangga University. Okay, Dr. Anda, time is yours for introduce JUV.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Dr. Hendrik, for the introduction. Good morning, ladies and gentlemen. My name is Andre Rizkiawan. I'm from Department of Oral Maxillofacial Surgery, Universitas Erlangga, the moderator of today's session. So I'm very happy to see you all here and welcome all you to this seminar. Today's seminar is about free tissue transfer in the head of and neck cancer surgery by Professor Chia Yu Wu. Before Professor Chia Yu Wu begin the session, I would like to read the curriculum vitae of Professor Chia Yu Wu. First, from July 2007 until present, attending Physical Division of Oral Maxillofacial Surgery, Department of Dentistry, Taipei Medical University Hospital, and as a director, Taiwanese Association of Oral Maxillofacial Surgery from March 2015 until March 2017. And from March 2017 until present, the director of Taipei Dental Association. And from August 2021 until present, the director, Department of Dentistry, Taipei Medical University Hospital. And from March 2019 and until present, as an assistant professor, School of Dental Technology, College of Oral Medicine, Taipei Medical University. And for the education, DDS, School of Dentistry, Taipei Medical University from 96 until 2002, and the Masters of Science, School of Dentistry, Taipei Medical University from 98 until 2002, and the PhD, School of Dentistry, Taipei Medical University, 2014 until 2021. And the specialty, head and neck oncology, head and neck reconstructive surgery, and orthodontic surgery. And for the international publication, so many international publications I cannot mention one by one. So before the presentation start, let me show you how to the presentation will go. First, the Professor Chia Yu Wu will give a presentation, and then there will be a question and answer session. So the next, I would like to invite Professor Chia Yu Wu to give the presentation. Please, Professor, the time is yours.
Yes, thank you, Mr. Moderator. Thank you for your wonderful introduction. Let me share my slide first. Okay, is it okay?
We can see your slide.
Okay. Good morning, ladies and gentlemen. I'm Joy Wu from Taipei Medical University. I'm very honored to have this opportunity to give a presentation to the friends from Erlangga University and my colleagues of TMU. Today, I'm going to share a topic on free tissue transfer in head and neck cancer surgery and focus on a specific flap named as posterior collateral radial artery perforator free flap. And I know my topic is a little bit different with the other topics this morning, but I know we have students here and maybe some dentists here and some oral and maxillofacial surgeons here. So I hope you will be interested in the topics I'm going to give you. My name is Jiao Wu, and I am an attending physician of the maxillofacial surgery department of Taipei Medical University Hospital, and I'm also the assistant professor of School of Dental Technology of TMU. And Indonesia and Taiwan and are both located in South and East Asia and share common problems, including the consumption of areca nut and betel nut consumption, which causes high incidence of oral cavity cancer. So my topic today will be focused on oral cancer and the treatment of oral cancer. It's very reasonable to realize that betel nut chewing rate is highly coincident with oral cancer prevalence, especially in southern and southeast Taiwan. These pictures show the common size that oral cancer could happen. In Taiwan, tongue and buccal mucosa are affected in the majority of oral cancer patients, and gingiva and the floor of mouth are also the common size of oral cancer. In Taiwanese male, oral cavity cancer is the fourth common cancer, while there are about 7,000 new cases a year, my bad. The incidence rate of oral cancer in Taiwan escalated in the past 40 years, and the average age of onset is 52. It definitely caused the heavy burden in patients' family and the nation's economy as well. Among the treatment modalities, surgery is the most common treatment for oral cavity cancer in Taiwan, which is followed by radiotherapy and chemotherapy. In early stage cancer, the majority of cancer patients undergo surgeries alone, although the indication of radiotherapy and chemotherapy increases in advanced oral cancer. Surgery still plays a role in advanced diseases. Up to date, we can say surgery remains the key element for treating oral cavity cancer and in most instances determines the outcome of the patients. That's why we still have to discuss the importance of surgical modalities, despite they have been developed for more than 100 years. When we talk about strategies for oral cancer surgery, both resection and reconstruction have to be taken into consideration. Additionally, the primary tumor would be resected with a safety margin ranging from 10 to 20 millimeters, according to the site involved by the tumor or the philosophies of the surgeons. For having clear surgical margins, some surgeons even advocate the principle of compartmental resection, which is removing an anatomic functional compartment containing the primary tumor instead of traditional 10 to 20 millimeter safety margin. For primary tumor at different sites, they are indicated resection margin respectively. Here I give you examples. For this buccal cancer, the natural boundaries are the upper and lower alveolus and the teeth medially and buccinator muscle laterally. Following the resection, the tumor was removed. Another example is a floor of mouth cancer. MRI showed that the tumor had already invaded the right side of the tongue and the floor of mouth. With compartmental resection principle, a segment of mandible was resected as a lateral margin, left 1/3 of the tongue as opposite margin, and epiglottis, the left bottom pictures, was removed as the posterior margin. Once the temporalis tendon was divided, the tumor was removed in a piece. In the specimen, the resection margin could be easily identified. Inevitably, the resection resulted in a huge defect which could not be closed primarily. These situations are quite common in oral cancer surgery. Even for small buccal cancer, maybe the defects are shallow and seem able to be grafted or just healed by secondary intention. However, either grafting or secondary healing finally cause severe scarring and treatments, which makes nutrition intake very hard and clinical follow-up almost impossible. Therefore, I emphasize reconstructive surgery is seldom unnecessary following oral cancer resection. Good reconstructive surgery can facilitate wound healing and minimize complications. In patients indicated for postoperative radiotherapy, a good reconstructive surgery guarantees that the radiotherapy can be initiated in time. According to the theory of reconstructive laser, free tissue transfer is the treatment of choice in most head and neck reconstruction following cancer resection surgery. Here I present several cases of reconstruction with free flaps. The first case is a flow of mouth cancer. Following resection, there were defects at right side of the mandible, the tongue, and the flow of mouth. A fibular flap with skin pedal was harvested. The mandibular defect was restored with the segment of fibular bone and the oral defect with skin pedal. The flap healed excellently without complication. And microvascular anastomosis is always carried out in free tissue transfer and is of essential importance. This man had cancers on both right and left buccal mucosa. The left buccal cancer even invaded the facial skin. For this patient, 4 flaps from the 3 donor sites were harvested. The left buccal defect was reconstructed with an ALT-free flap. Sorry. The mandibular defect was restored with a segment of fibular free flap, and the right buccal defect was repaired with a posterior radial collateral free flap. This gentleman had stage 4 lip cancer. The marked area was excised and the defect was reconstructed with ALT free flap. The appearance is satisfying and the lip function is excellent as well. For this patient with lower lip cancer, the tumor was resected along with a marginal mandibulectomy. We restored a defect with radial forearm free flap. Both post-operative appearance and function were acceptable. Another example is a patient who had right tongue cancer. Tumor resection with marginal mandibulectomy was done. The defect was restored with ALT flap. The patient can drink water smoothly without choking. The function after reconstruction should always be emphasized. For buccal defect, a good reconstruction provides soft and resilient surface which can maintain mouth opening. For bone reconstruction, we apply 3D printing technique to facilitate both resection and reconstruction. On the printed model, we can prepend and reconstruct prepend the reconstruction plate and fabricate the resection and drilling guides. Osteotomy can be carried out easily and precisely with the resection guide. After flap harvest, the prepend plate and the bone segment were fixed according to the drilling guide as well. Post-operative imaging showed the occlusion is restored very well. Teamwork is the core of the whole cancer surgery. Although there are fewer and fewer surgeons willing to do oral cancer surgery, we are proud that we still have young surgeons who devoted themselves in this field. Here I start the second part of my presentation, the posterior collector radial artery perforator free flap, a non-petticoat and versatile flap for orofacial reconstruction, which is an ongoing study in our institution. The term posterior collector radial artery, PRCA, perforator free flap is not well known. Instead, the other name, lateral arm free flap, is a more popular term to describe a flap from the human body's arm. In accordance with the Gantt consensus on perforator flap terminology, which was put forward in 2001, source artery plus perforator flap, this flap should be termed as posterior radial collector artery perforator flap. However, in clinical practice, lateral arm flap is the more frequently used term. Therefore, I will use both terms to make it clear in my presentation. Recently, in a review article, the author announced that the lateral arm flap is a primary option for defects requiring soft tissue reconstruction in head and neck. I think most of you could not agree with this statement because it's not the scenario we face every day. However, in our hospital, since we started to implement this flap in 2016, it gradually substituted the use of former radial forearm free flap. Besides the fact that the PRCA perforator free flap is a reliable flap, the versatility of this flap is a more important reason. In my presentation, I will mention the anatomy of the flap, the development history, the analysis of our clinical cases, the harvest technique we use, some clinical applications, and the future development of this flap. The lateral arm or upper arm flap was first described by Song in 1982 and further defined by Catros in 1984. Initially, it was introduced as a fasciocutaneous flap from the upper arm. The neurogenic artery PRCA is one of the terminal branch of the profunda brachial artery. There are two venous systems. The dominant system is from the concomitant veins that accompany the PRCA, which drain into the radial collector vein and the profunda brachial vein. There are some variations. For example, duplication of the PRCA occur in 3 to 10% of all cases. The vascular pedicle of this flap runs inside the lateral intermuscular septum, which lies between the triceps muscle posteriorly and the brachialis muscle and the brachioradialis muscle anteriorly. The radial nerve accompanies the vascular pedicle, and two of it, the PCNA and the PCNF, could be harvested with the flap as a sunset flap. Traditionally, the lateral arm flap has the advantages including pliable, suitable for small to moderately sized defect, with color matching to the facial skin, well compartmentalized fat, available nerve for grafting, and minimal donor site morbidity. However, it also has the disadvantages, including short pedicle length, small vessel caliper, and challenging flap dissection. It is therefore considered a secondary flap. Since it has been introduced, there are some modifications from the upper arm flap. Here I briefly present the development history of this flap. The first 15 years were the classical antiquity. In this era, there was a lot of cadaveric dissection, and most of the fundamental principles were built at this time. However, because of the short pedicle length, it was mainly applied in extremity reconstruction, not head and neck. The second 15 years were the industrial revolution. There were many large-scale case series, and by increasing the vascular pedicle length by some modifications, it could be used in head and neck and oral cavity. In the last 10 years, there were still some fine improvements, including the use of preoperative color Doppler sonography and some spatial design. The current concepts about this flap includes that it is suitable for small to medium-sized defects. The defect can provide skin, fascia, nerve, tendon, muscle, and even a nerve. And it is an lens extendable flap. Because of the rich vascular plexus and anastomosis around the elbow, it is possible to extend the skin paddle across the elbow to the forearm. Similarly, as a pedicle flap, the skin paddle from the upper arm could be nourished by the blood supply from the forearm. Here I quote the statement from 10 in 2000. That's for safety. A distally sighted flap should at least incorporate skin over the pectoral epicondyle. The other idea is to lengthen the vascular pedicle by positioning the skin pedal distally. This also echoes the concepts of perforator flaps. Once a reliable perforator is included, the skin perfusion can be guaranteed. Therefore, we can see many of the lateral arm flaps nowadays are designed around the elbow. However, here I present the 55 cases conducted in our hospital from 2016 to 2021. The mean ages of the patient is around 54, mostly male patients. The main cause of the defect is malignant tumor surgery, followed by benign tumor surgery, facial defect, and treatment surgery. The location of defect is buccal mucosa cases, followed by the tongue. We also use this flap repair the defect on the maxillary gingiva and the soft palate. 1/5 of the patients underwent radiotherapy before the reconstruction. We use the left arm more, mostly for convenience of the surgery. For example, when left side neck dissection was performed, we choose the right arm for flap raising, unlike the other author advocates flap raising on the left arm to avoid dominant arm mobility. But we don't think it's an issue because the donor side mobility is so low. The recipient arteries include facial, superior thyroid, and superior superficial temporal artery, and recipient veins vary widely. We conducted 2 venous anastomosis in 1/3 of the cases, mostly end-to-end anastomosis. The mean ischemia time is 71 minutes. The cause of failure includes 2 arterial thrombosis, 1 venous thrombosis, and a harvest failure in 1 earlier case. The mean postoperative stay is 8.7 days. The mean skin pedal length is 7.3 centimeter, ranging from 4 to 20 centimeter, and the width is 4.4 centimeter, ranging from 3 to 6 centimeter. The mean pedicle length is 9.7 centimeter, which is comparable to other studies. The mean distance between the most distal perforator and the epicondyle is 5.5 centimeter. We think the true vascular pedicle length should be the measurement of the part of vessels only, without fat, tissue, or muscle. This author claimed the vascular pedicle is 10 centimeter in length, but it is not true. The caliper is 1.33 millimeter in artery and 1.92 millimeter in vein. Sometimes we had to anastomose the artery small than 1 millimeter. So the artery is so small, so sometimes the anastomosis is very difficult to carry out. Here is the harvest technique we use, marking the lateral intermuscular septum between the epicondyle and the deltoid insertion, as well as the coordinate and the perforators marked by handheld Doppler, marking the skin incision 1.5 centimeter posterior to the septum, identifying the perforators. Distal ligation, the PRA, and design the skin pedal to catch the perforators. Distal ligation of the PRCA, circumscribing the skin pedal, and dissecting the lateral intermuscular septum. The PRCA here and the concomitant veins run with the radial nerve at the bottom of the septum. The final step is separating the radial nerve from the pedicle. The flap resin is done. Here are some applications. We repair this facial defect caused by radiation necrosis with PRCA perforator free flap. We can see a perfect color matching to the facial skin. We use this flap to repair the defect after buccal cancer resection most. The surface is soft and elastic. Another buccal cancer case, we observed many mucosalized flap skin several months after reconstruction, all with a wonderful result. Because of the extendable skin pedal length, we can restore bilateral buccal defect with one flap. For this case, a 12 by 4 centimeter flap was raised inset on bilateral buccal defect, removing the bridging part after automatization of the flap. The patient kept very good mouth opening. We can restore the defect on the maxillary gingiva because of long vascular pedicle. The tongue is also the common area where we use this flap. The pliable skin makes unrestricted tongue movement. Another tongue reconstruction, very good result. And another tongue. Both the volume and the functions of the tongue were restored. We conducted chimeric design in this case, skin marking, identifying the perforators, design skin pedal according to the law of the perforators, separating skin pedals, check, completing flap insetting. We also did a flow-through double free flaps, one PRCA and one radial forearm free flap. For this patient with lower lip cancer with facial defect caused by previous surgery, we did tumor white excision and scar releasing. The radial forearm flap and PRCA perforator free flap were raised. The contralateral facial artery was anastomosed to the radial artery and then the radial artery to PRCA. The concomitant vein of PRCA was connected to concomitant vein of a radial artery and then the right facial vein. Flap insetting. The donor side scar is usually inconspicuous, but sometimes obvious scar did happen. Finally, we provide an idea to tailor the thickness and tissue composition of the flap by orientating the skin pedal. If very thin skin is needed, the skin petal should be on the epicondyle. Moderate thickness, the skin petal could be placed on the brachioradialis muscle. Thicker tissue, the reverse eccentric skin petal, including the most distal perforator, is raised. We name it as a defect-oriented PRCA perforator free flap. For tongue defect, we usually need bulky tissue on the body and thinner and pliable tissue close to the tongue tip. Skin marking, incision line, subfascial dissection, choosing the perforator, design the skin petal on the ideal position, ligating the branches of PRCA and distal runout, circumscribing the skin petal, check, dissecting the pedicle, and complete the. So we can see very good matching to the tongue defect. This is vascular anastomosis. This is another case. We design the pedal very thin, the thinnest part to fit the defect on the mouth angle. We compare the PRCA perforator free flap and the radial forearm free flap. They are both pliable flap, and the PRCA flap has thin to thick design, while the forearm has only thin skin. PRCA flap matches the facial skin color better, and when a longer skin petal is designed on the radial forearm flap, the vascular pedicle will be shorter, but not the PRCA perforator free flap. PRCA is not a dominant artery, but radial artery is. PRCA flap has low donor side mobility, while the donor side of a radial forearm flap usually needs grafting. And sometimes this condition happens. So that's why we don't like forearm flap. I would like to recap the main points. First, PRCA perforator free flap is a more precise name for describing a flap based on the perforator from the posterior radial collector artery, no matter where the skin petal is located. And the second, the versatility of PRCA perforator free flap is from placing the skin petal flexibly. That's all I have. Thanks for your kind attention, and I'm pleased to take all the questions from you. Thank you very much.
Thank you very much, Professor Chia Yuwu, for your nice and interesting presentation. And the next session, we would like to invite all the audience to give a question. You can raise your hand, or maybe you can write in the chat box. Yes, maybe from the audience. Want to ask some question to Dr. Chia Yuwu? Anyone? If
yeah,
not,
maybe this is a very difficult topic for most of the audience.
yes,
okay.
Yes, Dr. Prof. Chia Yuwu, for the information, in our university, Universitas Airlangga, we have a resident of oral and maxillofacial surgery. So I think it's all of them maybe also attend in this meeting. Yeah, okay. From the chat box, we have a question from Michael Raharja. Thank you for the insightful presentation, Dr. Chia Yuwu. I have a question. What are the possible complications after the resection and the reconstructive surgery, and how do you cope up with them?
Okay, thank you, Michael. And your question is of importance in section and reconstructive surgery for oral cavity cancer. And because of my point today is free flap, so I would like to talk about the complications from free flap surgery. The most severe complication for flap surgery is the vascular crisis, which causes necrosis and failure after the surgery. So we also develop a algorithm to deal with the vascular crisis, to deal with the complications. But for now, the free flap is the gold standard for repairing the defect after oral cavity cancer. So despite of the complications, we still need this technique to repair the defect. So thanks for your question, and my answer is the most severe complication is the flap necrosis and the vascular crisis. And the best strategy to deal with them is to deal with it as soon as possible to fix the problems on the vascular anastomosis. And that's my answer. Thank you.
Very much, Professor Yu. And then for the next question from Dr. Prasida. Good morning, doctor. Thank you for your presentation. My name is Dika. I'm the resident of oral maxillofacial surgery from Erlangga University. I want to ask a question. One, in the case of flap failure, which flap technique has the fewest complication based on the clinical evidence?
Okay, if you are asking what kind of flaps, I would like to say, of course, local flap or pedicle flap is safer than free flap in most instances. But on the other hand, in most oral cancer cases, we cannot use pedicle flap because we have to repair a very big defect, and the defect is too far away from the donor side of a pedicle flap. So we have to use free flap. And among the free flaps, I would like to say maybe the radial forehand flap is the most safe flap we can use. And that's why the radial forehand flap is always the flap when a beginner in microvascular surgery to use for their case. So if you are interested in free flap surgery, I encourage you to use radial forehand flap first. But your later cases, you might need a very big flap, so you will need ALT flap and another flap to fit the need of the patients. Thanks for your question.
Yes, thank you very much for the answer, Professor Chia Yu. And from the audience, is there any question? You can raise your hand, or maybe you can write in the chat box.
Professor Anga, we need to proceed next section because time is closing to running.
Okay. Thank you very much. I'm sorry, I have one more question for you, Professor.
Yes, no problem.
So, how about in the cancer case, do you use the non-vascularized bone graft?
Yes, sometimes.
And non-vascularized?
Yes.
You use also non-vascularized bone graft?
Yeah, yes.
And for the cancer, is it immediately you apply the graft after the resection, or maybe you have to wait a moment to stable first, and then you have to operate again?
Very good question. And yes. My judgment is the need for post-operative radiotherapy. If the patient needs radiotherapy, I favor to delay the non-vascularized bone reconstruction after the radiotherapy. And if the patient had a very earlier stage cancer and the post-operative radiotherapy is not necessary in most instances, and we can repair the defect with iliac bone or fibular bone or other cancerous bone or particulate bone as soon as possible. Yes.
Yes, thank you very much for the discussion. I think it's very nice and interesting discussion, Dr. Chiawu. And I think we need meet face-to-face Dr. Professor Chiawu. And maybe if the situation is under control of COVID-19, maybe we can visit you in Taiwan Medical University.
Yes, I look forward to it.
Thank you very much. This is the end of this session. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Professor Chiawu. I see you. Bye.
Thank you.
Okay, thank you, thank you, Professor Wu. So also, please receive the virtual certificate of appreciation as shown in the screen. And I will show I will send the copy, hard copy to you after conference. And we also want to thank our moderator, Professor Andrew. And so we will also send you the hard copy to you after conference. Thank you all.
Yes, thank you very much. Thank you very much.
So now I would like to introduce our following moderator, Professor Weijin Lin.
Yes, thank you, Professor Peng. And next one, the speak is Professor Sihada, and talk about the digital implication to support a digital dental research community department in the University of Atlanta. So welcome to join ICDD. Okay.
Okay, thank you. Can I start?
Yes, please.
Thank you, Professor Peng, the Honorable Dean of College of Oral Medicine, Taipei Medical University, the Honorable Dean Faculty of Dental Medicine, Universitas Airlangga, the Chairman of School of Dental Technology, Taipei Medical University, the Honorable Committee and participants of this meeting. We are very happy to be together here, sharing our knowledge and experience in developing our education using digital innovation in many aspects. Hopefully, this sharing session would broaden our knowledge and to be the initial step to build our future collaboration. Actually, we are in more than 3,700 kilometers in distance, and we need to fly like 4 or 5 hours to get Taipei. But we are close enough in relationship actually by this collaborative meeting. About Surabaya itself, Surabaya is the second largest city in Indonesia that have nearly 3 million population. Surabaya is also the capital of East Java province, and the city of heroes. People say that Surabaya is the city of heroes, and our symbol is the shark and crocodile. This is a little bit introduction of our city here in Surabaya. And our campus, Universitas Airlangga, is located in the heart of Surabaya. We are the oldest dental school actually in Indonesia. and we are well recognized and well ranked in dental institution in Indonesia. After the brief introduction of Surabaya and my campus, my institution, I would like to start what actually we have done during pandemic and the post-pandemic to improve our education system using the digital innovation. Actually, in our campus regulation, we recognize the 3 commitments in higher education, or we call in Indonesian as Tridharma Perguruan Tinggi, 3 commitments in higher education, which consists of education, research, and community development. It means that we, as a teacher, we have to do the 3 things of the commitments. Though basically the 3 of them are the obligatory for all professors and teachers in the university. Every semester, we, the teacher, have to accomplish the 3 tasks. It is not enough for us to just to teach and do the research. It's not enough at all. But also, we have to perform the community development for the people. The 3 obligatory tasks have to be completed in any condition, including in the pandemic. So it is quite a particular challenging situation. Since it is very difficult and challenging, then digital innovation is the only solution to solve the problem. We learned something important and something beneficial from the long pandemics, that everything in the campus must be held properly in any condition, in any situation. The lockdown forced us to suspend almost all regular activities until we came to a conclusion that digital innovation must be developed to be struggled in any circumstances. We have to accomplish education, research, and community development in any condition, including in the pandemic situation. We have 3 kinds of classes in our undergraduate program. Consists of the first one is the regular program. The second one is the international undergraduate program. And the third one is the international dental course, which is the collaboration with Hiroshima University in Japan. After the students graduated from the undergraduate degree program, they all will enroll the next program, which is called as professional study program. We develop digital innovation in all study program, both undergraduate program and professional study program, to tackle and to be able to struggle the pandemics. The first thing and the most important thing to change, to challenge the situation is to change the conventional learning to e-learning. We move from the conventional learning, which have been used widely for a long time, to e-learning using our Moodle-based web application. It is very beneficial for teaching, giving assignments, examination, and discussion. And until now, we still keep developing this application for making it better. You can see the address of our e-learning, web-based e-learning program is the hebat.elearning.unair.ac.id. So every students and every teachers have their own accounts to run their application. After the pandemic, we try to start to organize or to perform a normal examination for students using e-learning application that I have mentioned before. in the CBT rooms, of course, we don't allow them to use their own laptop. So their equipment must be similar for all students. That's why we use the CBT rooms and under the surveillance camera. The situation is like this slide. We also started to perform normal practical work with the new standard, of course. We can see in the photo, it is the physiology laboratory works. You can see that the students learn to measure blood pressure to their friends in personnel directly. It is not possible to do online because measuring blood pressure and measuring pulse is the important competency for a doctor. So we choose for this activity to be organized or to be performed offline directly in personnel using our new standards. After the student graduated for their undergraduate program, they next they will enroll the next program, which is called profession study program. In our profession study program, we divide into the 3 phases: grade A, grade B, and grade C. In grade A, which the student learn the cognitive and psychomotoric through the Zoom. It is an online activity. After the student pass the grade A, they will go to the grade B, which the student will work in a mannequin or model in a campus. It is no longer online, it is offline. It is normal activity with a new standard, of course. After pass the grade B, they will go to the grade C, which the student will work on a patient to be the operators or co-assistant. Yeah, this is what happened in the grade A, which the student learn cognitive and psychomotor through the Zoom. It is online activity. We can see in the photo, this is the situation of a grade A activity. And what happened in the grade B? After the student pass the grade A, they will go to the grade B, which the student will work on a mannequin or on a model in the campus. It is no longer online. They go to the campus normally with the new standard, of course, using the personal protective equipment. They will learn how to don and how to doff, donning and doffing the personal protective equipment to protect themselves from the viral infection. This is what happened in the grade B. We can see that the students work on the model, on the mannequin, on the toy, yeah, under supervision of the teacher or the professors. And the teacher or the professor will score the works of the students. This is what happened in the grade B. What happened in the grade C? Grade C, after the student pass the grade B, they will go to the grade C, which the student will work on the patient in personnel to be an operator or to be the co-assistant. They work in the dental hospital, and the rooms for treatment, patient treatment, have the negative pressure using this, and the operator must use the level 2 or level 3 personal protective equipment. They have to be able for donning and doffing the personal protective equipment correctly. And we also arrange a limited number of the patient treated, and the patient must be screened with the antigen test in advance, and the maximum of treatment duration is like 60 minutes or 1 hour. The operator cannot treat the patient more than 60 minutes. It is not allowed. This is the situation in the grade C. We can see that the student work on the patient and personnel in the specific rooms, which is equipped by negative pressure, and the patient must perform the antigen test before they come to the hospital. So what we have done in educate our profession program student, so we can still have the competency, the good competency from the student in the pandemic situation. This is the rooms with the negative pressure. We can see the comparison or the difference between before pandemic and in the new normal or after pandemic, which is the after new normal right here, right now. I mean, in the recent situation, one student treat one patient in one chair side in one room in dental clinic and dental hospital, yeah, and maximum 60 minutes in treatment. And we can see the difference before the pandemic, 50 students in dental clinic with only 20 dental units in a cubicle, not in the room, but in the cubicle. Cubicles means the spirited rooms using the cubicle, not closed room. It is open actually. And 50 students work together in the 20 dental units. It means, I think it is very limited. This is the condition, what happened before pandemics. And after pandemics, it forced us to be more careful, yeah, for the situation. So we changed our policy that in the new normal, in the recent day and on, one student and one patient in one chair side in one room in a dental clinic or a dental hospital in the maximum treatment 60 minutes. This is the requirement for all operators to work in our dental hospital, including our students. The first one is, the most important thing is personal protective equipment or PPE. It consists of surgical mask, eye protection, including goggles, protective eyewear, full face shield or something like that. The third one is gown, protective clothing. And the fourth one is the N95 mask for dental procedure associated with aerosol. About the room itself, we also standardize our rooms and equipment, such as we have negative air pressure chamber with HEPA filter. We also have a high volume evacuator in air condition, of course. We also have dental unit water line. We also apply the UV sterilization light, extraoral aerosol vacuum, intraoral prophylaxis suction, hands hygiene tools and system, ventilation management, donning and doffing rooms, and shower rooms. How about the preventive protocol itself? The preventive protocols consists of personal protective equipment, mouth rinse before dental procedures, high volume evacuators or HVE, rubber dam isolation, anti-retraction handpiece, ventilation management, disinfection of the clinic setting, and the purification of airborne microbial pollutants. Other facility that we have is we have three simulation room with 35 dental mannequin models for grade B students. We also equip our connectivity with the internal package for the students and also for the teacher and the professors. We also subscribe Zoom meetings account, and we also provide the student with the lockers to keep their things during their work. That is the number one of our digital innovation in the education. We come to the digital innovation in research. I have to confess that during the big pandemic period, we cannot perform any research in the laboratory because our labs are suspended and closed. But we try to publish articles in a well-reputable international journals. We write our previous studies, and we write also reference. We also organize international meeting on a regular basis. This is the most important thing. After the pandemic, we successfully built and developed our research center. It is in the specific building, and we can facilitate the students to perform any kind of research in this office and to boost our research activity to be published in the international journal, of course. Beside the laboratory and research center to perform many kind of research in our institution, we also develop a theater and demo rooms. This is the demo rooms. We can see in the first photo, the audience can sit in their own seats. In front of them is the rooms for treatment, glass room for treatment, equipped with camera and of course negative pressure, and it is equipped by modern technologies such as 3D intraoral scanner like TMU showed in the first speaker by Professor Wei Chunlin. With Professor Wei Chunlin presentation, he mentioned about the 3D intraoral scanner. We can record intraoral condition or intraoral structure, and we can send the file to the dental laboratory for making the positive model or positive impression. The other facility is the demo room. Then the demo room is used for live procedures. It is for teaching. It is also for conference. For example, we can organize live surgery or live procedure to the audience and for all over the world, for international meeting, for instance, or for teaching. And we also equip our demo and theater rooms with the optical microscope to focus and to make the view of the oral cavity that treated in the better way with a high resolution camera, and the situation inside the oral cavity can be recorded and can be broadcasted and in the online meeting and for the teaching for the student. We also equip our basic medical science department with the camera-equipped microscope to teach online using the microscopic procedures. For example, the subject of histology and microbiology, the teacher can perform the microscopic movement or microscopic view in their way live for the student using Zoom or using other facilities or for international conference or something else, but it is quite beneficial to improve our education quality. We also perform the series of regular international meetings which have benefit for education because we invite visiting lecturers. We also, it is also beneficial for staff and student inbound. And the most important thing is this activity is recognized by the Indonesian Dental Association, and the certificates were issued by both university and Indonesian Dental Association. So the activity, the international activity is well recognized by any organization in Indonesia. With our efforts and hard works, we received many research grants provided the government in the year of 2021 and 2022. Thank God for this reward, just because our efforts and our hard work from all staff in Faculty of Dental Medicine, Universitas Airlangga. We also organize the collaborative event with the Tohoku University, which have the beneficial for education, visiting lectures, and staff and inbound student. I hope in the future, in the near future, we also have the same activity with the Taipei Medical University. I hope this collaborative meeting with the key point or baby step for implementing our future collaboration. Again, this activity is recognized by Indonesian Dental Association, and they both issued certificates for the participant of the seminars or the meeting. We have still have any different kind of meeting, international meeting during the pandemic. That is why I mentioned that before the pandemic, we rarely organize the international meeting, but after the pandemic, we organize more international meeting, quality international meeting, which is recognized by Indonesian Dental Association. And we gain so many number of participants. Number 3 is our digital innovation and our community development. This is the most challenging because almost impossible. It seems to be impossible to perform online community development activity. Yeah. Then the online activity with off-campus community are very challenging. I think educate people outside of the university using Zoom is almost impossible. But it is a challenge for us how to perform, how to organize the community development for the people to enrich the people, to empower the people outside the university, but in the online activity, it is very challenging. It is not easy to organize. It is not easy to perform. Because usually before the pandemic, we usually come to the community and we educate and we have a meeting and we have a training for them. But during the pandemic, I think it is not possible to perform. But we try to, we still try to organize the kind of activity. We organize a training to develop independent Google-based telemedicine for Indonesian rural dentists. We train Indonesian rural dentists to be able to make their own telemedicine, to be able to communicate with their patient during the pandemic using Google facilities, using Google application. We still, Indonesian rural dentists can communicate with the patient in the pandemic situation. It happened in the peak of the pandemic, not today. What we have done in the pandemic period, today everything is normal again. But what we have done in the pandemic situation at the time, the activity is the easy way to develop simple telemedicine application for daily practice for most Indonesian rural dentists. The activity was participated by over 300 rural dentists, and thank God, the activity received compliments and award due to the beneficial of the activity itself. And thank God, we can see the impact of our innovative community development, the ability of Indonesian rural dentists to develop their own telemedicine using Google-based application, and the activity is recognized by Telemedicine Development Center of Asia in Fukuoka, Japan, and have been published in international journal. So it is well recognized as an innovative activity to empower people outside of the university during the pandemic. Our innovation and hard work contribute successfully to the university to gain our prestigious rank in QS and SIMAGO rank. Actually, in the last SIMAGO rank, we are number 2 of dental institution in Indonesia. I think it is written in number 3. It is last year, but in the latest results, we gained number 2 of top Indonesian dental institution. But for our university, we are in the rank 465 in QS rank. We are in the top 500 university in the world in our university. And thank God, our faculty of dental medicine, contribute significantly for the university to get the prestigious rank. Just because of our hard work and our innovation. Then in the near future, again, hopefully, this collaborative conference is a baby step for us to start our future collaboration between Taipei Medical University and Universitas Airlangga. Thank you for your attention.
Professor Lin, Chairman Professor Lin, I have a question.
I think it's very well report about digital teaching and researcher. Maybe everyone have the question because time is up. So maybe we have the one question.
Professor Lin, do you hear me?
Yes, yes.
I'm Professor Sam. I have a question.
Yeah,
Professor Akasa, sorry, because Taipei Medical University will become the double language. We call them the bilingual university on the next 5 years. We call it the EMI course. For all courses use the English teaching. In the next 5 years, TMU will become a bilingual university. I want to know how about the University of Erlangen. Do you have some idea or schedule for the English teaching course for your school of dental medicine? Thank you very much.
Thank you very much. Let me share our previous slide. I mentioned that we in Universitas Erlangga have 3 kind of undergraduate program. The first one is regular class. It is an regular Indonesian language class. But for the number 2, international undergraduate program, all the course are given totally in English. Not bilingual, but totally in English. For the international undergraduate program, we receive like 30 students every year for from Malaysia and from neighborhood countries from in Indonesia, like Timor-Leste or Malaysia. But also the participant of international undergraduate program come from Indonesia also. It is welcome. We welcome everybody to join international undergraduate program. The most important thing for international undergraduate program is all the courses are given in English, not in bilingual. Then finally the student have to write their thesis or final project also in English. All the examination, all the tests, all the assignments, everything in academic activity for international undergraduate program is in English, is given in English. I think this is our situation, Professor Yushen.
Okay, thank you, Professor Aksa. Professor Lin, my question is ending. Thank you.
Yes, thank you, Professor Shen and Professor Sahanda. And the time is up. So, Professor Pong, thank you.
Okay, thank you very much. So, okay, thank you, Professor Aksa. So please receive our virtual certificate of as shown in the screen. We will show you the hard copy to you after conference. Thank you very much.
Thank you very much, Professor Peng.
Okay, and we also want to, this woman. So I also want to thank you, Professor Hadrat, for your time and efforts. So please receive the virtual certificate of appreciation as shown in the screen. Also, we will show you the hard copy after.
Okay, thank you.
Thank you very much. So it's time to say good afternoon and welcome to the closing ceremony. Now, I would like to invite the Vice Dean of College of Oral Medicine from Taipei Medical University. He will be delivering our closing remarks. Please welcome Professor Li Shen Chen. Hello. Professor Lee, Professor Chen is here. Okay, if possible, when we contact to Professor Chen.
Hello. Yes.
Okay.
Yes, I'm here.
Please go ahead. Go ahead. Yes, we need to hear your remarks, please.
Okay. Dear my friends and ladies and gentlemen, I, on behalf of the College of Oral Medicine, Taipei Medical University, to appreciate this wonderful conference held by each others, and I enjoyed today's very fruitful and remarkable speech by all the distinguished speakers from two universities. I sincerely hope in the near future we'll have a more deep collaboration between the two universities, and wish all of you stay healthy and keep in good contact. We will see very soon in the future. Thank you very much for your organization. Thank you.
Thank you, Professor Chen. Next, I would like to invite the Vice Dean of Faculty of Dental Medicine from Erlangen University to deliver his oration. Please welcome Association Professor Anda Rizkiwa.
Yes, thank you very much, Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Dean of College of Dental Medicine, Taipei Medical University, Professor Xin Chong Cheng. I'm sorry if I pronunciation is not good. The Honorable Professor Li Shenchen, the Vice Dean of College of Medicine, Taipei Medical University. The Honorable Professor Yung Kang Sen, Head of School of Dental Technology, Taipei Medical University, and all the participants. Good afternoon. On behalf of the Faculty of Dental Medicine, Medicine University Erlangen, I'm delighted to deliver these closing remarks on the success of the International Conference of Digital Dentistry 2022, which were held today. I believe that during the lecture of us has obtained a meaningful discussion. In this lecture, we have also learned a lot from the speaker who have shared their interesting work and experience. Once again, on behalf of Faculty of Dental Medicine, thank you for delivering such important materials so that all of us can deepen our knowledge. Furthermore, I would like to thank all the moderators for organizing this session and keeping things under control and reasonable on time. However, most importantly, I would like to thank you to you all the participants. Without your input and discussion, this lecture would not have been success it has. I felt along with many others that this webinar is very useful and should continue. So we are very honored if the Taipei Medical University will continue in this collaboration. Finally, I would like to thank all the committee for the organizing this lecture and the ensuring that it proceeds smoothly. I also like to apologize for any inconvenience that might your experience during this lecture. I thank you once again for your participation. I hope that you enjoy this lecture, and I do also hope that we can meet again in another occasion. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Professor Anda. So now we have come to the end of today's conference. Thank you for all your participation. Have a wonderful afternoon. See you next year.
See you next year.
You.
See you
Thank
next
you.
year.
See you next
Thank
year.
you.
Bye bye bye. See you next
Thank you
year.
very much.
Everybody.
Bye bye bye.
Thank you,
Bye
Professor.
bye.
See you.